Hey, hello everyone. Thank you for joining us today. I'm Michelle McGrath. I'm with Seabury Care Management, and we're here today to talk about long-term care and Medicaid. I'm here with Abigail Stanton and Abby Bullock from Elder Disability and Law Center, and I'll be talking today for a little bit, and then I'll be turning it over to Abigail and Abby to talk more about Medicaid and planning. So Seabury Care Management is our program is to help older adults maintain the highest quality of life. Our care managers and life enrichment specialists provide counsel, advocacy, coordination, engagement, and activities to help meet older adults' needs as they age. And we'd like to thank our sponsor for this series. It's just been wonderful to be able to reach out to the community. United Healthcare has made this possible. So thank you for joining us, and thanks for making this possible for United Healthcare. So I just want to congratulate you all for being here today. This is a difficult step wherever you're at on this journey. It can be very helpful to just know what your options are and what the information is to reduce the stress and uncertainty. It's a very complicated subject matter. So today we hope to bring some clarity about assumptions and what options are available for you. And we hope that you bring this forward to others to be a resource to family and friends and help maybe correct some incorrect assumptions that are out there. We're going to be discussing general information. We're not going to be able to respond to individual situations in this forum. And we do ask if you could put your questions in the chat, and then I'll be sharing those questions at the end of both of our presentations. So when you're looking at options, things to consider are the geographic area, what preferences you have, what are the supports available in that area. In the DC, Maryland, Virginia area, it's really important to think about which entity you want to live in because it does impact what resources are available for long term. You want to consider what your financial resources for you, and then also if there's long-term care insurance. And I'll be using the term you throughout, but that could also mean a loved one. So knowing what is available for you or the person that you're helping with the planning. You need to be really honest with yourself. What are the current and future expenses that you can anticipate and planning for those? And knowing what are the people within your circle? What are their experiences with aging? What opinions do they have about their own aging experience, and maybe what might be a good fit for you, and any suggestions that might be helpful or resources that work for them. And it's really important to deal with the difficult feelings that come up. And before making any decisions, be balanced between your thoughts and your feelings about the future rather than just avoiding or acting based on some really strong feelings. And with that in mind, planning before a crisis can allow for more choice, more autonomy, and certainly more control than if you wait for a crisis to occur when you don't have all the options available to you. And when you're remaining in your home, there might be some things that can be helpful while you age. So we are really lucky in the DMV. We have so many great senior villages that are in each community that offer a lot of programming, volunteer services, neighbor to neighbor support at a low cost. There's senior centers that are another low-cost option and that offer lunches and other ways to socialize, educational programs, trips, transportation options, many of which are subsidized and available to people with disabilities. We have home delivered meals, Meals on Wheels, which is programs that do have a cost for most, but can be available to low income. And I'll ask if everybody can mute. I hear some feedback. And some things to consider with remaining in the home as maybe costs increase are there may be ways to reduce costs through property taxes. There's Schedule H in DC for some deductions in your taxes. You can deduct medical expenses, accessibility modifications, but I would advise you to check with your accountant to see your specific situation, what could be deducted. Each entity, DC, Maryland, and Virginia, does have funds for repairs, weatherization, utility assistance, and reduction in energy costs in certain circumstances that can reduce your overall housing costs. And in some situations, you might be able to downsize or sell off valuables, bringing in a tenant to increase your monthly income. Seniors might have access to lower costing internet or cell phone services. And some people could choose to use their home equity through a HELOC, a home equity line of credit, or a reverse mortgage to increase the resources available. But again, check with your financial advisors before moving forward with that. And in DC and the surrounding counties, there are in-home respite care funding for a limited number of hours per year that can help get some care in the home and help with reducing costs. So when we're looking outside of the home, there's some general options available. The first is independent living, where there's continuing care retirement communities that have all levels of care, or also called life plan communities. And most people start in independent living in those communities. There's also retirement living for people 55 and older. That's usually all independent living, very much geared towards social activities, but also having a lot of shared resources and supports. And whenever you see 62 and older, that tends to be subsidized senior apartments. That can be lower cost living with some supports in place. And then this isn't an official type of independent living, but there are some places called naturally occurring retirement communities where you have condos or apartment buildings where people, just a large group, have aged in place and have shared resources and develop neighbor to neighbor services that can help maintain independence as people become impaired. And with subsidized, this is supportive living. We have at Seabury Friendship Terrace, which is a wonderful community for low-income seniors. And there are others in the DC metro area where if a person's income is 50% or less of the median income, that they could be eligible. Many of these places have long wait lists, so it's good to plan ahead, get on wait lists. And there will be a lot of paperwork. So there does need to be somebody who can complete that paperwork with the senior, or the senior doing that themselves. And then there's a lot of communities that have what's called in-house Section 8, where they can apply for their rent to be 30% of their income. And that is another way also to pool resources among residents. And then there's moderately priced senior apartments that are below market rate and also based on income. Then there's the next level of care is assisted living. And often people come through respite or just a trial to transition and see if it's a good fit for them. This is when somebody needs basic self-care or help with everyday living and support, like housekeeping and maybe getting to doctor's appointments, medication management. These might be large for-profit entities, or they could be nonprofit or even single sites owned and operated by a family or an individual. Some even look like homes in a neighborhood that you wouldn't even know from looking at the outside that it's an assisted living. And then there's memory care, which is either a separate place that is entirely focused on memory care, or a section of assisted living where people with moderate to significant dementia go, where the programming is specific to them and there's higher staffing levels. The costs for respite and assisted living vary widely, and we'll get into that a little bit more in a bit. And then there's the highest level of care, nursing home care. And nursing home care is 24-hour nurses and aide care. It doesn't, I think this is a misnomer. It doesn't have on-site 24 hours a day medical care. So usually doctors or primary care providers come in about 2 to 5 times a week, sometimes more frequently. Podiatrists, psychiatry often comes. There's rehab on site. But for any specialists, a person is going out to their offices or televisits. And the most common way people get into nursing homes is to start with a rehab stay following a hospitalization. And often at that point, if they're not able to go home, then they transition into long-term care. Many, but not all, have shared rooms, and they call them semi-private, which is usually 2 people per room. And it might be necessary to consider a nursing home if someone needs 2 people to assist them, like say getting out of bed, or they need a lot of close medical management, or they don't have the finances for other levels of care or remaining at the home. And Medicaid does require that a person needs a nursing home level of care physically, and also looks at the financial qualifications, and Abby and Abigail will get more into that. And these are just some charts to compare the different levels of care. It's hard to compare them next to one another, but just some considerations with remaining at home. The costs tend to go up as the impairments increase, and the home ages along with the person. So there might be added costs for home modifications, maintaining the home. And sometimes a home can become a place where someone becomes more socially isolated or physically unsafe, and becomes less desirable. CCRCs, usually there's this initial fee that's quite significant, and then there's monthly fees that go up as the level of care does. It's important to consider with CCRCs, assisted livings, that you research the entity that owns them to make sure that they're financially solvent, know your protections before signing any contracts. CCRCs are a little more extensive with the commitment. Assisted livings tend to be more month to month and giving 30 days notice. And the costs also vary quite a bit with larger assisted livings, and residential assisted livings on the whole tend to be a little less expensive than some of the larger for-profit entities. Memory care, a little more. When you're looking at assisted living, you have the cost for the level of care, medication management, and then the monthly rental, essentially. Memory care, this is generally speaking, not all places, but memory care tends to be an all-inclusive rate for once you're in memory care. And that's also true of nursing homes, that it's more all-inclusive rather than breaking down the costs by level of care. With nursing homes and assisted living, they may ask for families to hire a private aide to augment the care that they're providing if needed by the resident. And then when it comes to nursing homes, most, but not all, take Medicaid. So it's really important to know ahead of time if Medicaid will be a payer at a nursing home that you're considering. I'd say overall, it's important to consider your own cost of living adjustments and knowing that your costs will increase typically when there's a functional decline. Projecting for the next 2 to 5 years, none of us can tell the future, but considering the best you can, what the plans are and where you would want to live, and that your priorities may change. So as somebody is having more impairments, things like a culture of safety and a place that's reliable, a place that's near family or loved ones, a place that's kind, may become much more of a priority than the aesthetics of a place or the educational programs or the trips that a place may offer. So just things to consider as you're looking for the long term. And you'll have these slides so you can look these over yourself with who can help you pay for different kinds of care. Self-pay tends to be the main way people pay for care, but there might be programs within the county or DC level and then Medicaid that can help with paying for care as we age and have more impairments. And I want to turn it over now. Oh, I'm sorry. I did not give the proper introduction to Abigail and Abby. So I will turn it over to them in a moment. But I just wanted to say that Abigail Stanton is an attorney with the Elder and Disability Law Center. And she's the long-term care, Medicaid planning, estate planning, life care planning and management, and special needs planning practices. And she assists seniors and their families with navigating the many challenges associated with aging, including planning for disability, dementia, or diminished capacity, and asset protection and planning. Abigail is a certified dementia practitioner and a member of the National Academy of Elder Law Attorneys and is licensed to practice in DC, Maryland, Ohio, and Massachusetts. And Abby Bullock is an attorney at the Elder and Disability Law Center and is licensed to practice in Virginia and the District of Columbia. As the lead attorney for the probate division, Abby manages and administers complex estates, guiding families through the legal intricacies of estates and trust administration with compassion. Her practice areas include Medicaid planning, life care planning and management, and estate planning. And Abby is also a member of the National Academy of Elder Law Attorneys. And with that, I thank you for your attention, and I am going to stop sharing my screen and turn it over to Abigail and Abby.
Thank you, Michelle. So Abby is going to put our slides up. Okay, so thank you all for joining us. As Michelle introduced, we are elder law attorneys at the Elder and Disability Law Center. And so we're going to be talking about long-term care and Medicaid. So a lot of times when people come to us and they say, we want to talk about asset protection or long-term care planning, what they don't realize is that they are talking about Medicaid planning. So we're going to go through the basics today. We do have limited time, so we can't get into all the nitty-gritty details, but we will do our best to cover what you want to hear, and then we'll answer questions at the end. Okay, so first, I like to make sure that everybody understands what we're talking about. So what is Medicaid? So Medicaid is different than Medicare. Medicaid is a means-tested public benefit, and it's basically health insurance. Each state has its own Medicaid program. So some states have different rules than others. Each state has its own program that it administers separately. It's funded through federal funds and state funds, but the rules may vary from state to state. So we're going to be mostly focusing on our states today. If you're in a different state or you move to a different state, be mindful of that. Long-term care is a separate program within the Medicaid program that pays for long-term care supports and services. And so I also want to just address something many of you may be wondering about, which is the new bill that passed and cuts to Medicaid. We're not going to address that today. The bill does not address cuts to long-term care Medicaid. So there are cuts to Medicaid. We don't know what the states are going to do as they're shuffling funds around. So we're going to hold off on that until we see what happens. Okay, next slide, please. Okay. Within long-term care Medicaid, there are two types of programs. So we have the more common traditional long-term care Medicaid, which is nursing home-based Medicaid. So this is for individuals who live in a nursing home. Medicaid pays for room and board and supplies, things that are not covered by regular health insurance. It does not pay for assisted living, including memory care assisted living. So that's really important. And as Michelle went through, there's all different care settings, and you need to look at what is important to you. If Medicaid is on the table or you're concerned about Medicaid, you need to make sure that you're actually looking at nursing home or long-term care facilities. The alternative setting is home-based care. So different states have different Medicaid waiver programs, which are home and community-based services. So the waiver programs pay for aides to come and provide care in the home. So these are for people who are in their own homes. They may be living with friends or relatives, but Medicaid will pay for a certain number of hours per day for aides. Some people find this to work well. Other people may not receive enough care. So we never know how many hours of care someone will be approved for until they get approved for the program. So it's a little tough to know whether or not you're going to have sufficient coverage. So be aware of that. Next slide. Okay, so who's eligible for long-term care? So here's where we're going to get into the actual eligibility criteria. The baseline is individuals who are aged, blind, or disabled. So aged is 65 or over, who are medically eligible, which is different than being disabled, and who are financially eligible. And we're going to walk through the specifics of medical and financial eligibility. So for medical eligibility, Medicaid basically wants to ensure that the individual needs a nursing home level of care. So what that means is they're looking at the person's functional capacity. So there's different ways that you can meet the medical level of care. One way is if someone requires physical assistance with at least 2 activities of daily living. So those are specifically bathing, dressing, toileting, walking, transferring, and feeding. And feeding is not meal prep. Feeding is if someone puts a plate of food in front of someone, can they feed themselves on their own? So if you need physical assistance with at least 2 of those, you can meet a level of care, Medicaid eligibility. Alternatively, someone who has dementia or other cognitive impairment, they may be physically capable of doing all of those activities of daily living, but without reminders or supervision or cueing, they may not do them. So if someone has dementia and they do need that type of assistance, they need someone to pick out the clothes that they're going to wear so that they are weather appropriate, or remind them to change their clothes. They need someone to remind them, go into the shower, this is what you do in the shower, then that also counts. So you can meet a level of care if you have cognitive impairment and need help, not due to physical disability. And then lastly, if someone has a skilled nursing need, so something like wound care that actually requires skilled care. So that is the medical criteria, and I'm going to turn it over to Abby, who will go through the financial criteria.
Okay, thank you, Abby. So shifting now to financial eligibility. Financial eligibility really comes down to 2 main pieces. We're looking at income and resources. So think of income as what's coming in each month: Social Security, pensions, rental payments if you have rental property, but what's hitting your checking account on a monthly basis. Resources, on the other hand, are what you own, things like bank accounts, stocks, brokerage accounts, life insurance policies, and vehicles. So Medicaid is going to look closely at both income and resources to decide if someone qualifies. And there are limits to both. So we'll go over how much is too much and how not everything you own is counted against you in financial eligibility. Okay, so we're first going to start with income eligibility. When determining income eligibility, we are looking at the gross income of the individual who's applying for Medicaid. Medicaid is not looking at a non-applicant spouse's income, just the individual applying. So if there's a married couple, it's only the applicant's the applicant's income. The rules are going to be different depending upon the type of care you're applying for. So if you're applying for long-term care, as Abby discussed, in a nursing facility, the applicant's gross income cannot exceed the monthly cost of the nursing home in order to be income eligible. So by example, let's say the nursing home costs $10,000 a month and you're receiving $3,500 in monthly income. Your income is less than the cost of the nursing home, therefore you are income eligible for Medicaid. However, if for home and community-based services or Medicaid waiver, it's a little different. The applicant's gross income cannot exceed 300% of supplemental security income, or SSI, and this year that amount is $2,901. So if someone's monthly income is $3,500, they're not income eligible for waiver services. So that's income eligibility. Now let's look at resource eligibility. So not all resources count towards resource eligibility. Medicaid separates resources into two categories. We have countable resources and exempt resources. So countable resources are those that are going to affect your eligibility, and they must remain within the limits set by Medicaid that we'll discuss later. Exempt resources are the assets that don't count towards eligibility. They will still be reported to Medicaid, but they won't count towards the resource limit. Medicaid still has to verify that the asset is exempt, but again, they won't count towards the limit. Okay, so let's start by looking at exempt resources. So exempt resources, which you see listed here, are again the resources that Medicaid allows you to keep that don't count against you. So a lot of people worry that Medicaid is going to take their home. We hear that a lot from clients. The home property is actually an exempt resource if a spouse or a disabled child lives there. And also, for a single individual, the home property can still be exempt in DC if the applicant has the intent to return home and the value of the home property is less than $1,097,000. So other examples, as you can see here, include a vehicle, burial spaces, term life insurance, an irrevocable pre-need funeral plan. An irrevocable pre-need funeral plan is a prepaid agreement or contract between you and a funeral home that locks in your funeral arrangements ahead of time. So, and locks in the funds to pay for it. And in order for that agreement to be exempt, it must be irrevocable, which means that once it's set up, you can't cancel it and you can't get the money back. Abby Stanton will discuss supplemental needs trusts and Medicaid compliant annuities later in the presentation. In addition, there are some exempt resources that vary by state. By example, in DC, retirement accounts, including 401ks and IRAs, are exempt. Also, 529 plans are exempt, but those are countable in Maryland and Virginia. And in Maryland, rental property is exempt. Okay, so moving to countable resources. Let's talk about how much you're allowed to have. So countable resources, the assets that Medicaid considers when determining eligibility, the limits are listed here. So if an asset is not specifically exempted, then it's countable. And an individual is allowed to have a small amount of countable resources, and that amount varies by state. So as you see listed here, if you're applying in DC, it's $4,000. In Maryland, it's $2,500. And in Virginia, that limit's just $2,000. However, for married couples, there are protections in place so that the non-applicant spouse, who is also called the community spouse, isn't left destitute. So if you're married and only one spouse needs care, then the non-applicant spouse can keep more countable resources. And the amount of those countable resources that the non-applicant spouse or community spouse can keep is called the community spouse resource allowance. And I'm gonna send it back to Abby Stanton, who will now discuss the community spouse resource allowance.
You. Okay, so the Community Spouse Resource Allowance, we call it the CESRA for short, only applies for a married couple because we don't have a community spouse otherwise. And it's the value of the countable resources that the community spouse can keep and still have the institutionalized or applicant spouse be eligible for Medicaid. So in order to determine what the value of the CESRA is, Medicaid looks at the countable resources that the couple had on their snapshot date. So their snapshot date is the first day of the first month that the institutionalized spouse was institutionalized. And this is when I talk to clients, their eyes glaze over. So I'm going to try to make this easy to understand. So we have a snapshot date, which is one set date in time. That could be the first day of the month that the institutionalized spouse moves into the nursing home. So for example, married couple, both are at home, one spouse moves to long-term care. The first day of that month, that's the snapshot date. Snapshot date could also be based on hospitalization and rehab. So say we have married couple, spouse number one has a bad fall, goes to the hospital. After hospitalization, they're eligible for rehab and they stay in inpatient rehab for a while. If they're between the hospital and rehab, if there's a total stay of at least 30 days, then the first day of the month of the hospitalization is the snapshot date. So whatever the snapshot date is, we're going to look at what the total value of the countable resources were on that day. So when we meet with clients, sometimes they already have a snapshot date. It could be one spouse is already in a nursing home, or it could be that they're both at home, but the spouse that we're looking at Medicaid for was hospitalized and in rehab before. So that would have been a previous snapshot date. Or we're working with a couple that does not have one yet. They're both still home. They're looking for one person to move into a nursing home at this time. So whatever that is, we look at the total value of the countable resources, and Medicaid cuts that in half. The community spouse gets to keep one half, whatever that half is, up to a maximum. So depending on how many or what the value of the resources are, they may have exactly half or it may be capped. This year's maximum is $157,920, and that does go up a bit each year. So I'm going to go through a couple examples. So in our first example, we have a couple who had $200,000 in countable resources on their snapshot date. So when that's divided in half, half is 100,000. So that community spouse's CESRA is going to be $100,000. In example 2, Abby. Okay, in example 2, we have a couple with $500,000 in countable resources on their snapshot date. When we divide that in half, we have $250,000, which exceeds the maximum limit. So that community spouse is going to be capped at the max limit of the $157,920. So that's the calculation. The next question we also get is, what do we do with the other half? Is that what Medicaid takes? So first, I want to reassure everyone, Medicaid doesn't take anything. It's a threshold for eligibility. If you have more than you're allowed to have, you're not eligible. If you're under it, you're eligible. But Medicaid's not taking anything away during anybody's lifetimes. So when we're looking at what we have above and beyond the CESRA, if it's a married couple, or if it's a single person above what the applicant has, their little bit that they get to keep, that's what we're looking to protect or exhaust to get eligibility. So I'm going to walk through some options for resource exhaustion. You may hear the term spend down. Usually that's what this is referring to. So options for anybody. If you're over the resource limit, you can always spend the money. So Medicaid doesn't care if you spend your own money. That's fine. So it could be spent on care or it could be spent on other needs. You also can always purchase an exempt resource. So if you don't have an irrevocable pre-need funeral agreement, you can do that. If you don't have a burial space, if you don't have a vehicle, or you need to, you want to trade in an older vehicle and spend more money on a better one. So you can always use money to purchase exempt resources. Another option is using a supplemental needs trust. So a supplemental needs trust is a type of irrevocable sole benefit trust that can be used to pay for things that Medicaid doesn't pay for. I could take another 3 hours to talk about supplemental needs trusts, so I don't have time to go into the details. But the bottom line is they can be used. There's age restrictions, there are bells and whistles that go along with it, but it can be a planning option. For married couples, we often use Medicaid compliant annuities. So Medicaid compliant annuity also has a lot of bells and whistles and requirements, but in a nutshell, it's a way to purchase, to turn a lump sum of countable resources into an exempt stream of income. So you purchase a Medicaid compliant annuity with the lump sum of countable resources, and then the annuity is purchased for a set period of time. So say we have a 3-year annuity. Each month for 3 years, the community spouse gets a payment from that annuity. It's a way to recycle money back to the community spouse. You also can use money regarding the home. So if you needed to do repairs to the home, update things that you've been holding off, you can put money into the home. You can use it to pay down a mortgage or HELOC. And then also, Medicaid doesn't really care what you do with it, so with regard to the home. So if you just wanted a home makeover, you can spend the money on that. It's an exempt resource, so it's okay to put money into it. The issue with the home is that home repairs can take time. So you're not going to be eligible until you've actually spent the money or exhausted it. So you do need to be mindful of that. With regard to married couples, you're one unit at the front end. So Medicaid is looking at things that are owned by the spouses, whether it's in one spouse's name or joint, even if it's just in the community spouse's name. Medicaid's looking at everything. So it's important that all of the assets are factored in if they are countable. But once the institutionalized spouse is approved for Medicaid, then the couple is separate. Medicaid's not looking at the community spouse's assets anymore. The community spouse is no longer bound to that CESRA amount. So in the instance with a Medicaid compliant annuity, if the community spouse is getting these monthly payments and not needing to use all of that money for expenses, the community spouse can keep saving the money again. At this point, the community spouse could win the lottery and it's not going to jeopardize the institutionalized spouse's Medicaid as long as the assets are kept separate from that point forward. So with spouses, there's often good planning options. With single people where we don't have a community spouse to move things around to, it's a little tougher. There are also more complicated ways to protect assets, but we don't have time to go into those today. And those are do not try at home without assistance by an elder law attorney option. So we're going to leave that piece there. So next, I'm going to talk about the 5-year look back period. So the 5-year look back period is the period of 5 years immediately before applying for Medicaid. So date of application, backwards 5 years. During that 5-year window, Medicaid wants to know, were any gifts made? Gifts or uncompensated transfers? And if so, they may put a penalty period on the person applying for Medicaid. So first, what is a gift? What counts? So a gift can be anything that is an actual outright gift, whether it's money or something else of value that you're giving to another person or to a charity, anything like that. It can be a sale of something for less than fair market value. So for example, if you have a car, you're selling it to a family member, maybe the car is worth $20,000, you sell it for $1,000 just to be nice. The $19,000 difference is going to be treated as a gift. And then also failure to accept an asset. So if you are the beneficiary of someone else's estate and you say, I'm good, I'm not going to take it, that would be a gift. The value of the inheritance you didn't take is a gift. There's not really a minimum threshold for gifts. DC doesn't really have many exemptions at all. Maryland has a decent amount of exemptions depending on the circumstances. Virginia has a little bit, but it's really a case-by-case basis. And some of this is going to be based on the caseworker who's reviewing the case and what they consider to be significant or not. So really, when you're thinking about gifts, anything can be a gift. So what happens if you have made gifts? So if you have made gifts that are going to be penalized, Medicaid then calculates out the penalty period. So this is done by taking the total value of the gifts that were made within the 5-year period and dividing them by a penalty divisor. Each state has its own divisor. DC's is just over 15,000, so we're going to use round numbers right now. So if you've made $150,000 in gifts within the last 5 years, Medicaid would divide that by, let's call it 15,000, which would be 10 months of penalty period. So what that means is you're eligible for Medicaid, you've applied, they've determined that you're eligible, but they are not going to start services for 10 months because you are in a timeout for 10 months. So during that time, if you are in long-term care, you're applying for regular Medicaid and you're in a nursing home, someone else has to pay for your care during those 10 months. There are some exceptions. Transfers between spouses are exempt. Transfers to minor or disabled children are exempt. Transfers to supplemental needs trusts. I know I didn't go into detail on those, but if they meet criteria, they are also exempt. But it is important that you're mindful of these gifts because a lot of people do make gifts to kids as a matter of course, or other families or charities. So, there's not a baseline exception if you're making annual exclusion gifts, if you are, regularly making gifts to others. It's important that you're talking with an attorney about whether or not that's going to affect your Medicaid eligibility in the future, or that you have a plan for what to do if there is a penalty period. So I'm going to hand this back to Abby. She's going to finish up with some planning.
Okay, so when it comes to Medicaid planning, one size definitely doesn't fit all. Your situation, whether you're single or married, whether you're already in need of care or planning ahead, makes a difference, and so do your goals. For some people, the primary goal may be to stay in their home as long as possible. For others, it may be about leaving something behind for their children. And for many, it's a mix of both, preserving quality of life while protecting assets for future generations. So the needs and strategies will look very different. By example, a single adult in their 70s might be thinking about assisted living versus a married couple where one spouse is still healthy and the other is facing a possible nursing home stay. So each scenario requires a different approach and needs thoughtful planning. So what can you do now? Start the conversation. Talk to your loved ones. The earlier you start having these conversations about your care and your finances, the more options that you'll have. Also, make sure you have a strong, durable power of attorney in place. Someone you trust to act for you if you're not able to. We could do a whole presentation about powers of attorney, and we won't go into detail today. But if you have one and haven't looked at it in a while, pull it out and review it. Or if you don't have one, it should be a priority to get one. Also, Abby just spoke about gifting. Again, be mindful of gifting. Giving to your children or to your grandchildren or making annual gift tax exclusion gifts are uncompensated transfers. And they may result in a penalty period if Medicaid is needed within 5 years, within that 5-year look back period that Abby just discussed. Also, when you're ready, connect with an elder law attorney. An elder law attorney can walk you through your choices and create a plan that is in line with your goals. I think we will now open it up to questions. Michelle, are you gonna take a look at the chat?
Yeah, so we had a question here, and please do add your questions as we go here. Is countable resource limit a monthly amount?
So the countable resource limit is a total amount. So what Medicaid wants to make sure is that a person is staying under the countable resource limit. Eligibility for Medicaid is based on the first day of the month. So for Maryland and DC. So if you want to be covered for a specific month and then ongoing, you need to be eligible as of the first day of that month. So basically, the night before, your countable resource limits has to be below, if it's DC and you're on Medicaid, $4,000. So that way, on the first minute of the next day, you are starting the month with $4,000. Now, when someone's on Medicaid, the amounts are going to fluctuate within the account throughout the month because their income's going to come in and the amount's going to go up. What matters is that at the end of the month, it's back down. And we didn't really get into post eligibility and the application and what happens when you're on Medicaid. But basically, when you're on Medicaid, you do have what's called a patient liability or a patient pay amount. And that is based on your gross monthly income. So Medicaid looks at what your gross monthly income is. They have some exceptions that you get to keep money for, like health insurance, a personal needs allowance. If there's a spouse, sometimes the spouse gets to keep some, but the rest gets paid to the facility. And so every month your income comes in, you pay the facility, it goes back down, and so you're back down, if we're in DC, to no more than $4,000. So it's a monthly basis that you have to be mindful of.
Okay, thank you. And I'll open it up. Does anybody have any other questions for myself or Abby or Abigail?